Hello, this is Austin, and today I will discuss the hip and anatomy and what makes it function and the joint itself. Later on in the presentation, John and Jalen will discuss the major injuries that occur in the hip, and then Blaze will finish the presentation off at the conclusion. So, the introduction of the hip. It is a very unique anatomically, developmentally, and physiologically. So for this, clinicians, therapists, and other health professionals need to understand the basic structural of it and the biomechanics. The hip joint acts as a central pivot point for mostly the whole body. It needs to stay healthy for people to just walk properly with their gait, and it has most of it is because the joint has lots of pressure and forces that are placed on it from the ground up, from pressure of walking, and as well as forces that are being carried from the head, trunk, and upper extremities. Hip instability is a big problem, mostly for the older population, but in recent years, research has increased and has new information regarding hip diseases. Although the hip is known to be less stable, it is fairly a stable joint because it requires a lot of force to dislocate it, and it to remain as stable as possible for us to complete like the smallest task. It is just very important. And bending over at the hip or lifting a foot off the ground and rotating the trunk at the hip will cause the hip and musculature around it to stay activated and healthy. So the joint itself, it is a true ball and socket joint, and is supported by many strong and well-balanced muscles and ligaments to enable the wide range of motion and free range of motion it mostly has in all the different planes. Even with all this free range of motion, it holds the stability during the movement, unlike most other joints. The hip meets all four characteristics of a diaphragmal joint, which is a joint cavity. Joint surfaces are covered in articular cartilage, a synovial membrane producing synovial fluid, and surrounded by a ligamentous capsule. And due to the joint being very unique in multiple ways, it also makes it tougher to diagnose. This joint, just like all other joints, need to remain stable. X-rays for imaging on the hip are not particularly the preferred method. The preferred method is mostly a MRI, and has been seen as a better tool for processing on the hip than the anatomy. So there are three bones that make up the cerebellum. This is the ilium, which is 40% of it, the ischium, which another 40%, and then the pubis, which covers the last percent, which is 20%. The only thing separating the three bones is a triradiate cartilage which begins to fuse around the ages 14 to 16. And then around the age of 23, the fusion is usually completed. The articular surface that is seen while looking in the cerebellum is lunate or horseshoe shaped like. Near the rim of the cerebellum is a labrum that is composed of fibrocartilage, and it runs the whole circumference of the cerebellum. And then the labrum isn't known for the stability, but it's mostly plays a part in the development and separation of forces placed on the joint. And like I said, it's not too much for the stability. The femur, it's the largest bone in the body, and the head is covered by an articular surface or articular cartilage that allows for just more range of motion. And with this, when 60 to 70% of the femoral head is covered by this cartilage, and the remaining percent is for the insertion of the ligamentum teres on the head of the femur. Body size also influences how big the femur can be, and just the length of the neck, which is the middle of the head and the shaft. The angle of the head and neck of the femur changes throughout our lives, and it starts around 150 degrees at birth, and then it slightly declines to 125 degrees at an age of an adult. So the design of the hip promotes rotational movements and directional movements in all the different planes, and due to most all the large muscles and the large number of the muscles. There are a total of 22 muscles that help with the stability and the primary movement of the hip. The muscle anatomy of the hip can be divided in 3 distinct groups. The first group are in inner hip muscles. The second group are outer hip muscles, and the last group are muscles that act as adductors. So to get into the different muscles and all the different planes, the sagittal plane, also the frontal axis, the primary hip flexor is the iliopsoas, which is a thick muscle comprised of the psoas, and psoas major and minor, and the iliacus. The origin of this muscle is T12 through L5 multiple bodies, and it inserts on the lesser trochanter. The primary hip extensors are the gluteus maximus, hamstrings, and the posterior head of the abductor magnus. The largest muscle of the hip is the gluteus maximus, and this runs from the lateral aspect of the dorsal sacral surface around the posterior side of the ilium to the gluteal tuberosity to where it inserts. This muscle also allows for external rotation as well as abduction and adduction of the upper and lower fibers. So the frontal plane, also the sagittal axis, the primary hip adductors are the pectineus, the adductor longus, adductor brevis, adductor magnus, and gracilis. The secondary hip adductors are biceps femoris, gluteus maximus, the quadratus femoris, and the obturator externus. Then the primary hip abductors are gluteus medius and maximus and tensor fasciae latae. The secondary hip abductors are the piriformis, the sartorius, and the rectus femoris. So the last plane, the transverse plane, just the vertical axis, it allows for external rotation, and in the hip, it is done by the gluteus maximus and the 5 of the 6 short external rotators. The secondary muscles for this action are the gluteus medius and minimus, obturator externus, the sartorius, and biceps femoris. The internal rotation is done by mostly secondary muscles, not a true primary muscle that causes this rotation, but secondary muscles are the gluteus minimus and medius, adductor longus, and a few others. And then the ligaments. Ligaments usually consist of type 1 collagen, but in this hip joint, it's mostly done by type 3 5, 6, 11, and 14. And due to this, it mostly causes a lot of um, instability in the hip. That's mostly due to different types. The ligament in the hip, however, will have just a higher ratio of type 3 collagen. And then those three primary ligaments, the iliofemoral ligament, the ischiofemoral ligament, and the pubofemoral ligament. And additional ligaments that play a small role in instability includes the ligamentum teres and its zona or orbicularis, which is just the ankle ligament. And here's my references.
All right, so in this next section, we're going to talk about femoral neck fractures, exactly what kind of structures that have already been discussed are involved, and we're going to spend a lot of time on how they are assessed and treated and how they occur. So first, we have the bony anatomy involved. First, we have the articulations. So the head of the femur, as you can see in the picture, sits inside the acetabellum, and usually this is a very strong articulation with all of the other soft tissues and such that surround the head of the femur, but aren't necessarily involved with this injury. So the joint, the true hip joint, the ball and socket joint that is the hip, is the joint involved, but probably not exactly how you would think. And then the bone is the femur, more specifically the head of the femur. So not the long portion of the femur, what people picture, but the upper portion that juts off into the hip. So soft tissues involved, while there are tons and tons of soft tissues involved with the hip itself, when it comes to this injury, there are no ligaments or muscles that are attached that contribute to this injury. They play a factor in the formation of the hip and the structure of the hip, but they do not play a factor into this injury. So I'm going to spend a lot of time on the epidemiology of femoral neck fractures. So first thing to know are there are three types of femoral neck fractures. Femoral neck fractures are most commonly stress fractures, and they are compression fractures, displaced fractures, and tension fractures. The standard, most common mechanism of injury for femoral head fractures are traumatic posterior hip dislocation, so such as a car wreck or a really tough fall. But this is usually paired with natural degenerations of bones or osteoporosis. So you more commonly see this injury in elderly population, and that raises a ton of other questions on how this injury will heal. So because when you get this injury, the blood supply can also be damaged. Not only would it be difficult to heal for a young and healthy individual, but when you consider an older individual who may already have other health issues on top of this degeneration of the bones, it is a very, very difficult injury. It can sometimes be paired with a posterior dislocation of the hip, and that is considered a medical emergency and should be taken of immediately. So next, some signs and symptoms of a femoral neck fracture. So the most common is pain in the groin that gets worse when you put weight on the hip or try to rotate the hip. So just any pressure or movement of the hip will cause pain, and this is easy to determine and figure out because it is a significant pain. This is how the rest of the leg connects to the body, to the trunk, and if it is completely broken or ruptured, this is obviously going to cause a tremendous amount of pain, along with the many nerve endings and blood supplies that run through the hips. But this is coupled with the elderly population because older people typically may have bones that are weakened by osteoporosis or maybe cancer or some other kind of medical condition, and leading up to the injury, they might have experienced groin pain previously before they were officially injured. So assessment next. So most doctors could usually determine a femoral head fracture by the hip and leg position, usually because it is coupled with a hip dislocation. So the head of the femur coming out of the acetabellum. But if they can't, they'll refer for an x-ray, and if the stress fractures are very small or hairline fractures, they could refer you to a CT scan, an MRI, or bone scans. So bone scans would be the most accurate because you're injected with a dye that seeps into your stress fractures in your bones, and they light up on a bone scan. But after the initial physical examination, most, if not every doctor, will refer you for an x-ray, or if an x-ray doesn't reveal as much as they would like, they would refer you to one of the other three types of scans, a CT scan, MRI, or bone scan. So treatment will almost always involve surgery, and I say almost always very specifically. There used to be treatment that did not involve surgery, that it just involved bed rests, tons of time off, and little to no movement, which could lead to muscle atrophy. So they're now, the majority of which are managed surgically. They can be repaired in usually one of three ways. So one would be screws, as you can see on the screen. The screws enter the lateral side of the femur, and they screw them up into the femoral head to lock that bone in place. Another, if the injury is severe enough, the doctor could do a partial hip replacement or even a total hip replacement if the head of the femur is just beyond repair. So this is usually determined on whether or not the hip is also dislocated. So if they are not able to reduce the head of the femur back into the hip, they will almost always go with surgical intervention. So next, biomechanics and range of motions. So the hip is a Similar to the shoulder, it is an ball and socket joint. It is a little more stable than the shoulder, but it is still involved in all movements in most every direction to some degree or another. And it functions in all three planes of motion, which means you have your frontal, sagittal, and transverse plane. The hip is involved with extension, flexion, rotation, abduction, adduction, just every movement and plane and axis possible. Just to a lesser degree than the shoulder, because the hip is a more stable joint as a whole, but even though it does have this great range of motion, that does leave it susceptible to more injuries if you're not careful. But that's all I have prepared. I have my references. First page, second page. All right, thanks.
My name is Jalen Gladney, and I'll be discussing hip dysplasia. Hip dysplasia, bony anatomy, articulation. The head of the femur articulates with the acetabellum. The acetabellum is just a socket, and the head of the femur is the ball. It's the ball and socket joint, where the head of the femur enters the acetabellum of the hip bone and forms the hip joint. The joint is the hip joint, and bones included in this disease are the femur. Hip dysplasia, soft tissue, ligaments. Ligaments around the joint are tightened and restrict free movement of the femur. The ligaments involved in hip dysplasia are the ischiofemoral ligamentum teres, and acetabular labrum. Muscles. The iliopsoas, gluteus medius, and minimus will have decreased stability roles when the hip dysplasia occurs due to morphing and decreased stability of the hip joint. If left untreated, a dysplastic hip can lead to acetabular labral tear. This is a tear of the soft tissue that lines the hip joint socket. Hip dysplasia epidemiology, etiology. The earliest that hip dysplasia can develop is in the womb, when the infant's position puts pressure on its hip, shifting the joints out of socket. Signs and symptoms. Hip pain, limping, but not subjective to pain. Pain when walking, running, pain in the buttocks, and muscular aches. Assessment. The types of assessment are hip alignment, bone scans, MRIs, and x-rays. Treatment. All forms of treatment involve surgery. There are two types of surgery for hip dysplasia: preservation and total hip replacement. POA surgery. POA stands for periacetabular osteotomy. Divides bone structure of the acetabular and shifts it to realign better. Total hip replacement. Replacement of the hip joint with specific metal and hard plastic parts to replicate hip joint and function. Hip dysplasia, biomechanics, and range of motion. Biomechanics. The hip joint is capable of all movements. Range of motion. Stiffness in the ligaments and gradual decline of the soft tissue in joint socket lead to limited range of motion in the hip. Signs of arthritis are present. The hip expresses movements in all planes.